So this is the case. So what do you think of, I will ask some questions. What do you think of this right CTO? Easy one, tough one? What are the criteria you are looking for? So it's a long CTO. There is no ambiguity on the proximal cap, and maybe there is a small channel, so that's good news. And we saw that the distal cap is at the level of the bifurcation. So who would start antegrade and who would go directly retrograde for a case like that?
Start antegrade first.
Yeah, we did that because the positive criteria for this approach was the channel we just saw on the dual injection, and we start with a smooth, soft wire, which is an XT wire, and with Elong microcatheter. And it was quite easy to progress until this part in the micro channel. So any of you have any experience with the Elong microcatheter? It's a very good microcatheter, I must say. Really, it's here with T, but it's a microcatheter you will manipulate counterclockwise to advance. And it's very strong against fatigue, so you can really
rotate many times.
Yeah, as many times as you want.
But all rotations should be anti-clockwise.
Anti-clockwise to advance it. And always, when you manipulate microcatheter, don't forget not to use only the right hand, but use both hands to do the anti-clockwise movement to really transmit the force to the tip of the micro. So, really you can be hard with Elong because it's really a strong microcatheter. The pushability is good, the profile is very nice, and it will be some micro when you struggle a little bit with macros, you will feel the wire sticking inside, and you will have at some point to change the micro. With this one, you can really be hard on it and do whatever you want. So this is, we are progressing towards, so we are still in the architecture of the vessel, so we are quite happy progressing with both with the wire and the mic. But now you can see that we are not in the distal lumen of the RCA. Maybe we went a little bit up at the end of the CTO here, and we miss here we should be like this, and we miss the distal cap, and the wire is too. So at this point, for sure, you will have to stay with the micro before the bifurcation if you don't want to lose the bifurcation. If you are not sure you are in the distal lumen, don't advance the micro further. So it was time to change the strategy or complete the strategy by a retro approach. So you let the antegrade wire in place, as you can see. You remove your Elong microcatheter either with an extension or with a simple trapping, and go back with the same micro retrograding. That's why in our cath lab we only have 150 centimeters micro, because it's not very problematic to use them in antegrade procedure, but you can always use them in retrograde procedure. And you don't have to have 135, for example, and say, okay, now I have to go retro, and 135 will be too short, so I have to take another microcatheter. So it's quite expensive if you have to use 2 or 3 micro per procedure. So the same micro here, and you see that the way is quite tortuous, but it's going with a CO03 going in the PDA. So another tip at this point, don't hesitate to let the wire going very far in the branch to have a good support to advance the micro, and it's don't feel don't stay here with the wire. If the wire advance like this, let it advance. It will bring you good support to advance the macro easy. So you see the Elong is now in the PDA. We do a tip injection to confirm the position of the wire. We perform a puncture in the distal cap with a Gaia 3 wire. And you see all the work we have already done integrally is now very useful because we will be in perfect position to do a reverse cart. So everyone is okay with the concept of the reverse cart, or do you want a small explanation? No, it's okay for everyone? Yeah.
Yes.
Yeah. So the one important tip, if you bring an extension, it will shorten the need for going up to the guiding with the micro. So it's very interesting to have an extension to facilitate the externalization. And we aim to do that in most of our case now. So the reverse cart, and you see the other device which is interesting here is extension guiding catheter, the Expressman. And why is it interesting? Because the Expressman have side holes, and it's really impressive to see the pressure, which is not never, but almost never dumped with the Expressman deep in the artery. So it's very comfortable because you don't have EKG modification, dumping pressure, fear of injection. And you see here the Expressman is at the level of the distal right, and still the pressure is normal. So this is the reverse cart and then predilatation. So we can see that there is here default of inflation, and maybe that's why the antegrade wire was deflected outside the vessel lumen. So focal, probably a focal calcification with which needed non-compliant balloon same image. So we used OPN balloon at 50 atmosphere in order to crack the lesion, and to you see here the lesion is finally opening, and we see the final results with 3DS. So any question about this case?
You did predilate before the extension to the right or not? You did predilate the right.
Yeah,
was
sure.
the
Sorry.
CTO,
Yeah,
like,
yeah. To advance the Expressman, it was a predilatation of the first part of the CTO. It would be nice if it's going like this, but you have to predilate to, and always the best way is to predilate and use the inflated balloon to gain support and advance the Expressman. So we've done this case last week. So again, a right. You can see the length seems so not so much ambiguity. We know it's we need to go like this. We need to go here, but somehow between the two, it's quite not so clear and maybe not so straight. But the technique was at the beginning almost the same. Gladius EX wire. So this case was performed by my dearly associate, and maybe for me, I would rather use a soft wire to begin, because the Gladius is a very nice wire, but you will go more easily in the subintimal space, and maybe it works to spare 5 or 10 minutes with a softer wire, XT, XTA, XTR, whatever you want, and then switch to the Gladius. So the Gladius here you see is going down. So here it seems okay, but not really dancing with the distal part of the vessel. And we have to stop here the antegrade advancement because we were not going anywhere, and soft wire don't work, stiff wire are dangerous because the path is unclear. So again, the strategy was to advance the Elong retrogradely. So you're here now. I will freeze the image here. So you have your first wire here, here the second wire. So what could be your solution now to solve the case? Check which wire will you use, retrogradely, antegradely? What will you do now?
What is the wire? Which guide?
I think at this point it was feeder XT. Yeah.
Maybe you can knock over to guide.
Yeah. So that's a very interesting point, and maybe you will solve many of your cases like this when the path isn't clear, when you have tortuosity, you don't know where to go. Knuckling within the CTO body, there is no risk, and you will solve the case very easily and elegantly. So you have to do a knuckle. You see the knuckle retrogradely and antegradely with fielder XT wire. So the loop here is a little bit big, so you don't want to advance too much with such a big loop. But you now have the two wires, antegradly and retrogradly, in good position here to perform the reverse cart. And you solve the ambiguity of tortuosity. You are for sure in subintimal space in both antegrade and retrograde, but it's not the worst part, the more difficult way to do the reverse cart. So again, here you have to bring antegrade balloon. Again, you have the Expressman in the mid RCA. And for this case, which size of balloon would you choose for the reverse cart?
Again, please.
Huh?
Again.
The question is,
The size. So you for the reverse cart, you have to inflate a balloon.
Yes.
Antegradly. And which size of balloon, which diameter of balloon will you use in this case, for example?
Smaller balloon.
Should I make sure at first that the two wires are
true or
in
not?
space? Or we
No.
know
You have performed a knuckle, so they are in suboptimal space. They come both, but it's not a problem.
We should check it's a true lumen or not.
No,
in a small balloon.
it's not a problem. You imagine that here it's a gray zone. You don't know where you are. Maybe if you don't perform knuckle and the two wires are in a good position, they can be either subintimal, intraplaque, antegradly or retrogradly. Here we perform knuckle, so the both wires went subintimal. It's not possible that they are intraplaque.
but I will use at least 3.3 balloon,
Yeah.
3.5.
Sure. And the purpose of the reverse cart is to break the walls between the two wires, whether they are subintimal, intraplaque, or everything. So you need, if you take a too small balloon, like 2.5, it will be very difficult to break all the walls between the two wires. So to perform a good reverse cart, when the two wires are in place here, they are dancing, you are confident they are in the architecture of the vessel, you have to take a balloon at the size of the vessel if you want the reverse card to be effective. So at least 3 balloon in this case, okay? So that's very important. Don't be shy with the balloon of the reverse card. If the smaller the balloon, the more difficult the reverse card.
So if the 3.0 won't work here, you would go with a bigger balloon, like I don't know, the size of a knuckle, most probably, because you
Yeah,
want to touch the knuckle.
3.0, 3.5 is okay because it's a very big right coronary. For sure, if the artery is 2.5, don't take a 3.5 balloon. But in this case, it's a really big right coronary. And the principle, you inflate your balloon, you take generally a stiffer wire, you bring the Elong microcatheter near the balloon or on the balloon, and you will inflate your big balloon, try to puncture it with the retro wire, and then deflate and advance the wire to go inside the Expressman. Okay, so that was done here, and you see the problem of this case. There was a lot of tortuosity here. The Expressman was able to go up to there, but we were not sure to be able to go too high. So we have now the retrograde wire here. And we are not sure we will be able to advance the Expressman within the extension, the Elong within the extension. Want to take a RG3 or a long wire to make the externalization. So what can be the solution here? You manage to have the retrograde wire inside the guiding catheter, but yeah, so 2 options. You can trap here with the balloon, but sometime with extension, you have to be careful not to take a too big balloon. It will give you strength in order to advance. And the other option, do you know the tipping technique or rendezvous technique? So it's working very well. The only thing is you have for sure to take another microcatheter. So the principle is to bring a second microcatheter antegradly and to enter the antegrade microcatheter. I should have a video of the TP here. Yeah. I will do this. So you see a second Elong is now here. You will go generally in the curvature of the omoplate is the best way to do the tip-in. So you bring the nose of the Elong at this point, and with the retrograde wire, you will try to enter the antegrade microcatheter. It seems difficult saying like that, but in fact, it's really hyper easy. So try it, and you will see. You will see the wire enter the microcatheter. So a good tip is to have in the microcatheter a workhorse wire. You let the workhorse wire 10 centimeters from the nose of the microcatheter, and you will feel the retrograde wire touching the antegrade wire within the microcatheter, and you know you're inside, and then you will advance the antegrade microcatheter on the retrograde wire and go to the distal true lumen.
Should you do this with a long wire, 300 centimeter, or with regular wire?
Regular wire is okay. And you see now we advance on the, so we remove the retrograde Elong, we advance the antegrade Elong, and we are in the distal true lumen, and we can finish the case.
Without externalization with anti-grid wire only.
Yeah. So, yes, that's the beauty of the tip-in technique. You don't need to externalize. you just have to advance on the retrograde wire, the antegrade microcatheter, and it's working very well. And you see the result of the case with we were a little bit disappointed by the calcification here, but the result is okay.